Hello, everyone, and a very good evening. Hope you all are doing well and keeping safe. I am Chandini. I will be the IT facilitator for today's session and will be there to assist you throughout the session. Before we kick off the session, let's all stand for our national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you. Today's webinar topic is Advanced Manual Therapy Booster for Physiotherapists. IAPWC Bihar has organized this webinar under the guidance of IAP India. For a hassle-free webinar, please follow the instructions which I am reading out. Sit in a quiet location where you will not be disturbed. Use appropriate equipments. Please post all your doubts, queries on your right-hand side of screen in chat window. We will get back to it at the end of the session in question and answer round. On this note, I would like to invite Dr. Smita ma'am to take this webinar forward.
Thank you, Chandni. A new broom sweeps clean, but the old broom knows the cost. The sacred of change. Focus all of your energy not on fighting the old, but on building the new. Manual therapy has a long history within the profession of physical therapy, and physical therapists have greatly contributed to the current diversity and mechanical explanation is historically used to explain the mechanism by which the manual therapy interventions work.
Excuse me, Dr. Smita, your voice is not clear. I request you to keep the mouthpiece close to you.
Thank you. Well, interactions work. New research reveals interaction neurophysiological mechanisms are also to play, and the beneficial physiological efforts of providing hands-on examination and intervention should not be ignored. Well, the aim of this webinar is to make physiotherapists understand hands-on body work is a feature of therapeutic interactions in traditional cultures around the world. Namaste to all and a warm welcome. Before we start with the webinar, I would like to welcome a very strong lady who stands up for everybody. She is beauty with brains. Her name does not need any explanation today. Her hard work and dedication have made IAPWC a brand. She is none other than Dr. IAPWC from Treasure IAP. She believes if you don't have a dream, there is no way to make one come true. And if you don't have big goals, you'll end up working for someone that, and she has proved it. Over to you, ma'am. I guess she has not yet joined. Well, now I would call upon Dr. Vinay Pandey, sir. Are you there, sir?
Dr. Ruchi
Yes, I'm there.
joining.
Okay.
Okay.
Dr. Vinay, you can please start.
So Vinay Pandey, sir, he is Vice President for
Dr.
IAP
Smita,
Bihar
Dr.
chapter.
Smita,
Yes,
Dr.
sir.
Smita.
Yes, sir.
Just I heard Ruchi has already joined. So
Okay.
let us go one by one as we have decided earlier. So
Okay,
let
sir.
Ruchi speak. Okay.
Okay, sir. Okay, sir.
Go ahead,
Welcome,
please.
ma'am.
Ruchi ma'am, are you there? Can you please speak up?
Yes, she is joining. So Dr. Ruchi is with us.
Welcome, ma'am.
Welcome. Thank you, ma'am. Good evening, good afternoon, everyone.
Very good afternoon, ma'am.
Hello.
Yes, ma'am. Over to you, ma'am.
So on behalf of technical team IAP, we welcome Dr. Ruchi Vashne. She has joined amidst her busy schedule. So please help me welcome ma'am. We have begun with the introduction and it's over to you now.
Thank you, everyone. Thank you, Manish sir, to accept the invitation and bear with us. और सभी पार्टिसिपेंट्स को बस इतना बोलना चाहती हूँ कि मनीष सर जो हमारे आज के एस्टीम स्पीकर और रिसोर्स पर्सन हैं वो तो दिया है, उनको रोशनी दिखाने के हमारी औकात नहीं है. सर इज फुल ऑफ ही इज द ट्रेजर ऑफ नॉलेज और मैं आईएपी ट्रेजर होके इस ट्रेजर को बहुत ज्यादा अपने पास और चाहती हूँ कि सभी लोग सर से उनसे वैल्यूएबल नॉलेज को उनके साथ उनसे सीख सकें. थैंक यू सर. इस कोविड-19 पीरियड में बहुत स्ट्रेस है. टुडे वी लॉस्ट वन ऑफ आवर physio and I was feeling very low because he was a dear friend of mine. So इस पीरियड में आप लोग थैंक यू जो इस स्पिरिट को मेंटेन करके रख रहे हो सभी लोगों की. थैंक यू स्मिता मैम और आपकी सारी टीम स्माइल के साथ ये सब कुछ लेके आगे लेके जाने की. एंड आई एम वेरी श्योर सर ये वन ऑफ द मोस्ट मेमोरेबल वेबिनार होगा हमारा आईएपी इंडिया प्लेटफॉर्म पे. थैंक यू टू द टेक्निकल टीम ऑफ आईएपी इंडिया. Thank you, sir. Please. Thank you.
Thank you, ma'am. Thank you so much for your awesome guide. And then you are awesome, ma'am. And you're always there for us and for your support and guide. Like we are moving forward, we are moving ahead with your help. Thanks a lot for
My
the
pleasure.
support, ma'am.
My pleasure. Thank you. Thank you. Sir, over to you, sir. Manish, sir.
Now I would like to call upon Vinay
Thank
Pandey,
you.
sir.
Achha, okay. I didn't see. Good evening, sir. Vinay, sir. Good evening, all the esteemed guests. I didn't see anyone else. I only saw Manish, sir, and Smita, ma'am.
Good evening, Dr. Ruchi.
Good evening, sir.
Dr. Manish Arora, sir.
Manish, sir, unmute.
To
Good evening,
unmute
Manish, sir.
yourself.
I unmuted. I was listening, so I didn't want to say. Good evening,
Oh,
everybody.
Okay. Good evening, sir. And thank you, Dr. Ruchi, Dr. Smita, and of course, technical team of the IAP. So to get me connected to this August people around all over from India. Of course, Manish sir is my senior, and we are alumni of the same institute, and it is always nice to hear Manish sir. And as Dr. Ruchi rightly said कि सर सूरज हैं, उनके लिए कुछ बोलना सूरज को दिया दिखाने जैसा है. So I think we'll be having a very fruitful booster, manual therapy booster from him, because he is having more than 20 years of experience in manual therapy, and presently he is Foster and Dean of has been this time together, Manish sir and me. And I feel all of us are going to benefit it like never.
Hello. I think I'm facing some connection problems. Uh, can you hear me all? Smita, you could message me if you can hear me.
Yes, sir.
Yes, sir. We
Yes,
can
sir.
hear
I
you well.
can hear you.
All right. Thank you. Actually, I was not getting your voices, so I was a little perturbed by the fact that whether my
Yeah, please, Smita, ma'am, you can go
Yeah.
ahead with the announcements.
Thank you, sir. Thank you, Vinay, sir. Thanks a lot. Now, I would like to call upon Dr. Uma Shankar Sinha, sir, Secretary, IIP Bihar Chapter. Over to you, sir.
Uma Shankar, sir, are you there?
He's not in the panelist, I think.
Dr. Uma Shankar hasn't arrived yet. We were
He's-
waiting for him. He
Oh.
hasn't arrived yet.
He's not. Yes,
Oh.
he's not in the panelist. We should go ahead with the lecture.
Yes,
He's
ma'am.
not.
So, well, he believes education is not built the mind with a lot of facts, perfecting the instrument and getting complete mastery. He is a person who encourages minds to think, hands to create, and hearts to love. He is someone who has nourished the souls of his students for a lifetime. He is none other than Dr. Manish Arora, sir, Professor and Dean, SBS PGI Dehradun, and hero of the show. Sir, thank you, sir, for accepting the invitation. And over to you, sir.
Sir, unmute yourself. Manish, sir, unmute.
can you hear me now, all of you? Please?
Yes.
Yes, yes.
Thank you. First of all, I would like to congratulate the IAP teams, both the central team led by Dr. Sanjeev and Dr. Ruchi Vashne, and the local Bihar team, Smita, Dr. Vinay. I'm so happy to see him again after such a long time. And all the members who have put in such a wonderful effort. I think the way the presentation started, I was mesmerized. I am doing a webinar in India or I'm doing somewhere abroad. So wonderful layout for the webinar, the way a video was designed probably by Dr. Ruchi Vashne. It was a treat to watch. And I'm sure whatever little knowledge I have, I'd like to share with you all here on this platform. And that's what I can do. I'm a professor. I can only talk about the biochemistry and the biophysics of the body, not much more beyond that. So that will be my intention. But thank you very much for letting me out here among you all. It's wonderful. I
It's
feel really
our
great.
honor,
Thank
sir.
you.
Completely our honor. Thank you. Thank you, sir.
So I'll put the screen share.
Yes, sir.
Put my WhatsApp here. In case there's some audio problem or some problem, please let me know. Because sometimes when you're talking, you cannot get the feedback back.
So we'll
Yes.
keep you posted, sir.
Thank you.
And
Thank you.
we are live on YouTube also, Sumant. We are live on YouTube.
Yes, we are live on YouTube as well.
All right. Okay, sir.
Right. Thank you, Dr. Samant.
Yeah, thank you.
Right. So that's what I want to show, an advanced manual therapy booster to our physiotherapy practice. Why I call it as a booster? Because I feel we need something drastically to change to make ourselves very apt, very strong professional to handle a lot of problems. And things are changing. We're becoming better with time. Every day, some new techniques are coming. We are learning new things. But still, I feel we still need a big boost. And a similar thing happened to me about 8 to 10 years back when I was feeling a little low with my practice. I was doing a reasonable job, but it wasn't as flourishing as I could have ever thought. But then I started learning a lot new things in manual therapy, and it changed or revolutionized my way of working. And previously, I could only cater to patients who could only be coming from 2 kilometers or 3 kilometers around my clinic to find a physiotherapist. Now, with all your blessings, I do get patients from all pan India. Even as far as Bihar, I have patients from Calcutta coming to me from the eastern zone. So this is all what changed my practice. And I don't advertise, it's the patients who bring the patients. So that's what I want you all to really master that skill so that the profession of physiotherapy in India is left with no stones unturned. It becomes a real uh, jewel in the healthcare industry. So definitely Council IAP is making a lot of efforts, and I'm sure we're going to have it. And then we are looking for a lot of other things. But I think what can change this profession in this country is the way we start changing our abilities to work. So a little bit, but I can share in this 1 hour. I'm here. They've already told you that I'm working as dean and professor at SBS University. I've been trying to keep myself updated, trying to learn from the best in this world. Been going around, hunting for new things, and not only learning new things, but I want my profession to grow up from this country as well. So we have been trying to build up research, been presenting papers, we have been writing papers, and we have 3 papers at WCPT, and one of them, myokinetic, my own method of assessing the muscle dysfunction, is there now, which is a trade right with us, and it was well documented and well published. Well, not going more about myself, but more about this profession. Science is a continuous process of evolving towards better and better. That's what we have been seeing. Today, I'm doing a webinar sitting so far away from all of you because of this science development. Who could have thought 30, 40 years back that even you could see somebody on screen? I am from a family where people were in telecommunication industry, and to call somebody, we used to have a trunk dialing where somebody could listen what you were speaking, and today we could directly talk to each other. And same has to go with physiotherapy. What we learned was good. What we are learning is good, but what we want to learn should be even better. That should be the objective, because the problems in human body are not very simple as they look. A single thing which looks like a back pain has multiple sources of problems. The problem is we treat one kind of a disc problem. We say, oh, now I can treat because I manage that person. But that person who comes next may have a similar presentation of pain, similar presentation of symptoms, but yet he may have a different way of getting treated. Why? Because this gentleman, if you see, first when he had his bulb fused, he changed the bulb and it started getting better. But next time, when he tried, it did not work because the fault was somewhere else, or it may have been somewhere else. The same with the human body. It's not a simple circuit where there's one battery and one light source monitored by one switch. It is very complicated. A single problem, like, let me talk about supraspinatus spasm. It can come because your muscle was overstrained by working, or it may also come when your humeral head was jolted into anterior inferior direction. So that made the humerus head go away and the muscle was pulled. So the muscle became a victim. So in first case, when you overstrained your muscle by lifting like this, you will put a needle or you would release that muscle, it will all become better. But if the humeral head has been jolted out, the muscle will be constantly pulled unless you make the head go back. The same problem, we had two different ways of treating it. So this is how we have to find where the problem is coming. And not only we need to find the problem, but we need to have a lot of tools to treat these problems. Nothing in this world works with a single tool. We have to have very specific kind of maneuvers to treat each problem that we get. Like for this example, this nail cannot be driven back by a screwdriver, how better screwdriver we have. So whatever you learn, dry needling, manipulation, mobilization, taping, all these things add to your artillery, and we need to add and make better. Now, before we go ahead, let me warn you, there are many things which are sold for the sake of marketing. And many things which we are still using are still being advocated, though they are not that effective as they appear. I've taken an example because I believe there may be many students here of sesame oil versus olive oil. Olive oil may not be actually better than sesame oil, but we use a lot today because that is marketed that way. So this is what we need to get rid of, that thing. We need to find evidences of what things work and what do not work. You don't believe me? See this example. This is a fairness cream. I think these are the biggest selling creams we have in India. But do they work? If they work, this boy would not have looked this way. Definitely, this gentleman had all the money, and this man would have looked away on the right side of the screen, not on the left side of the screen. So many things are being propagated, and similar are things in our profession. I've been a very strong supporter of electrotherapy. This little research I'm putting, not because I want to show that electrotherapy doesn't work, but rather I want to show that we need to find those things which are not that effective and rather replace them with more advanced things. This little research, if you see on ultrasound, and it is a meta-analysis of many researchers. It is not a single article that I've chosen which may be having some bias that it is not working or this is working. And Smita, she has been my student, and I could see many of the students when I was seeing the list of the participants growing. I've been teaching electrotherapy and ultrasound myself. But if you see, it is shown that actually ultrasound is not effective in chronic pain or many other problems which we have been using. You may have some contradictory experience to what I am telling. Why so? You may say, we had applied ultrasound on the patient and he felt better. Yes, he felt better because many problems in the body are self-limiting. So if you can assure the human body system that everything is settling, the nervous system, there's a here spender of things which is called a central sensitization, peripheral sensitization, and over relay of a pain, which is masked by the assurance only. And with your simple application that something is being done, the patient starts feeling better. And this is not what I say, the research says. If you see, this is the work of Robin McKenzie, which says that 44% of people with low back pain will automatically become better after 1 week, even if we do not give any treatment or we give placebo treatment. And 86% of those people will become better after 1 month. Now here, you may ask me one question, then why also we need manual therapy if the people are going to become better on their own? The reason for this is, it is not just temporarily masking the pain, which is very important. It is the long-term effect of that dysfunction that needs to be minimized. When stress comes on a system, the patient does an unusual activity or more activity than he normally does, he gets some pain because some muscles are triggered into dysfunction. With little bit of rest, he may become better. But next time when he takes more stress, he may get that pain which does not become automatically better, and he sees a medical help. If we do not intervene, still with a little bit of here and there care, it may be Dadima's nuskas, it may be a medication, a pop-up pill from a doctor, or it may be a little heat or a little touch by a therapist, he may feel better. But if you see this blue line, the pain temporarily becomes better, but it keeps on coming back, and it may even come worse after some time. In contrast, if I work on the myofascial elasticity restoration, that is a combination of strength and flexibility, elasticity. So if I work on that, this problem does have a much less chance of coming back, and even if it comes back, it will come with much less intensity. So that is what I want to emphasize. Our objective is not just to mask the pain, but to treat it. I'm going to come a lot more on that in a few slides. Another little thing which we need to realize when we are working on our patients is that we have an overbelief on certain things, like, for instance, I have this MRI system. In today's world, if you ask a patient what does bring him to your clinic or what problem he has, most often my patients today say, sir, I have an L4, L5 problem. Or, sir, my L5 is there. So, for 20 years back, they used to come with, sir, I have back pain, I have neck pain. Now, the gimmick of overselling this MRIs has led to the extent that any patient with any problem, we send him with an MRI. And what we get, we start believing on this. The way we buy watermelons, the way the person sells it to us, oh, it's good. He shakes and gives it to us. When we come at home, we find it tasteless and colorless. So similarly, certain things like that can happen with MRI also. I don't say MRI is to be discarded. It's a wonderful tool. It can lead and give us a lot of things, but this is oversold. It's a journal in USA in 2005, that's a spine journal, and then the Neuroradiological Journal in 2014 says one patient, 10 MRIs were done, and there were 10 different reports. And not only this, these are the MRIs of those patients who do not have any back or neck pain. If you see on the left-hand side of the screen, these are the MRIs of lumbar spine of people who do not have any pain ever. Still, 80% of them 80 have disc herniations, and 20% of them after 20 have disc herniations. The cervical spine, this data is no different. It is even worse. So I may have a disc which is not bothering me, but then I do an overactivity straining my gluteus medius, which brings the same pain of perceived as a radicular pain in my leg. And what I will do, I'll send the patient for an MRI. MRI had a disc which is already herniated. I'll start treating traction with traction and other things, but the problem was somewhere else. It was in the gluteus minimus muscle. A simple release or a trigger inhibition of that muscle would have decreased that thing. If it was having a general disc problem, definitely we'll treat that. But many times it's the disc not creating compression, but the MRI always shows this kind of bulges, even if they are producing any symptoms or not. So that's what we need to identify. There's another example. If you ever thought that this are the muscles only bring sciatica? No, this is the kidney going down. If your hepatorenal ligament, the kidney is weak, the hepatorenal ligament is weak, the kidney will go down and press on the sciatic nerve. I had this patient who had gone a kidney transplant. When his new kidney was transplanted, it was a little down from the normal side, and he had an irreparable sciatica. So people were treating for his disc problems, but it never worked. I could even diagnose, but because he had a transplant, we couldn't touch and mobilize his renal tissue. We couldn't treat him, but then we could find the source. So there are many things which need to be discovered, and that's what we try to do in manual therapy. We have to dig it and make it more and more advanced. One little effort is to change the vision, the thought process when we see a patient. Previously, when a patient would come with a shoulder problem, I'll try to hunt everything in the shoulder and treat it. It may become better or it may not become better. But now, with my manual therapy vision, I sometimes treat his shoulder or neck pain from his feet or maybe from his pelvis. Now, we had this illusion that we could divide the body. The similar illusion that our geography teacher gave us when he showed us this map. And we were so, when I was young, I wondered what actually was separating these two countries. Was there a wire or there was a road or what there was? But actually there was nothing. It was all man-made. We have disputes in countries about the land because we don't have a division made by God. And similarly, there's no division in human body. Nothing works independently. All work in harmony. So one organ which is not functioning problem or one structure which is not functioning problem can affect the other. If I have my foot supinated on one side, it will start creating a lateral rotation of my femur and tibia and will make my ilium go posteriorly and my shoulder will drop on one side. When the shoulder will drop on one side, there will be traction on the muscles above and they may go into spasm. And I have a pain which is coming from my foot. And I'm treating these muscles day in and out, and I make the patient get some heat. It becomes better. 2 days. Again, the pain comes back 2 days later. So we have to change that vision. As I said, the body is connected from head to toe. This is a little example. If my little part here, like my pelvis rotates, it affects my entire spine up to the cervical spine. This is another example on the right-hand side screen. His temporomandibular joint is changing the tone in his entire body. So if we work here, we make his entire body tone change become better. This is the reverse I was talking about, this, the foot supination and pronation, the drop arches and over arches. They say you can have good arch only at one place, either your spine or your foot. If your spine has good arch, that means probably, or overarch, probably your foot has lost their arch. And probably if your foot are arching too much, the spine will lose its arch. So that's what I'm going to say. Everything is interconnected, and that's what we need to take. This is an example of an occipital bone. When it is out of alignment, it is shifting the sacrum from its position because they are connected by dura. So the myodural structures attached on my head can influence my sacrum. So it can go the other way around. And there I would require a sacral release technique. I may keep on manipulating, mobilizing my sacrum. It will not work unless I start releasing my occiput and the dura which connects that. Now, I said before, I'll go again on that, and that is we are not going to work only on the symptoms because symptoms are sometimes misleading. Pain is like an alarm. So if pain is bothering you, you need to find the cause of that, not to switch that off. If there is some smoke and there's a smoke detector in your room and that beeps, you don't switch it off before switching off the fire. I've made this little example comparing it with grass. The symptoms and the roots, that needs to be segregated. Sorry. If you see this wonderful carpet grass has certain weed grass. That damaging grass which spoils the texture of the beautiful grass here. And it's very similar to certain aches and pains that we get in our joints. So we cut that weed grass out of the carpet grass, or we give some temporary solutions to the patient's pains and we do not treat that thing which has brought the symptom, it will all come back. It will all grow with time. And it will grow to the extent now it will be creating a problem in the entire area. Similar things happen with your joints. They keep on degenerating and becoming worse. And we come to a stage where we need to dig it out and throw it out and replace it. And that's why we are having approximately 300 to 400% more TKRs in this century than it used to happen in the years of the previous century. It is not because our knees have suddenly become more brittle or weakened, now because we are trying to get them quick healing and not correcting the faults. So we need to take things out of the root. We make the people have that strength and the elasticity come back. We need to have the joints aligned back to get rid of these problems. Another example I have is with this atlas rotation. I just wanted to show because there's something which is growing very nicely today. I said nicely, I didn't say very badly. Nicely because as a physiotherapist, it is to my liking because it's my bread and butter. We are so glued on our mobile phones every time we are like this, computers, that we are getting faults in the upper cervical spine. And if you see, this is the atlas vertebra. And when this atlas vertebra will rotate, it can press upon not only the nerves which are coming around it, but it can press upon to this vagus nerve. So I may get a little pain, which I may make better with mobilization or with my heat therapy. But if I don't take care of the vagus, it can create severe problems like raised heart rate, hypertension, increased acidity, weakness, fatigue, migraine, or sort of headache. All these things can come. And this is one publication we have where we treated this upper cervical dysfunction and we corrected the resting heart rate of people in a senile age and the people of older age, geriatric population. So we could make their heart function better by doing the correction there. Now, this is what we need to differentiate. I have three pictures here. One, the pain is coming because of the postural fault. Second, if trauma has knocked the bone into a misalignment. And the third, if there is inflammation. All will have a similar presentation of pain. All the people will have pain because there's an inflammation, redness, heat, and they'll have pain. If I give the umbrella cover of electrotherapy and cryotherapy, all will become temporarily better. But in the first case, where the pain had only come because of a minor tear or a minor pull, and it was inflammatory, it will never come back. But in other cases, like the postural fault or the traumatic misalignment, it will all come back. And we get these kind of problems day in, day out. They're growing because we love to have these kind of problems ourselves. Right. So whenever there's a trauma or there's a fault, the bone gets misaligned, as you can see in this video. There's everything healthy, nice, all the nerves coming nicely, sending green signals to the tissues where they should send. But then this kind of misalignment, if you see, when it happens, it presses the nerve here. And when the nerve presses, you get this dysfunction. Slowly, as with time, as shown in the previous slide also, this can grow into disc prolapses, spondylosis, and all kinds of physio problems. So we need to treat that. And then again, this is a course where I said advanced therapy. People thought a misalignment is there, all you need is a manipulation. Of course, manipulation is required. But then that manipulation has to be scientifically calculated and arrived at. It cannot be a simple click like this. A pop can always give you relief. And that's what even those people who are non-qualified will show you a lot of things on YouTube. And they'll have people coming to their clinics and quacks. They'll manipulate and patient will start instantly feeling a little better. Or even the barbers do that, to my surprise. But they are not very sure whether they actually treated the joint or not. Sometimes they do that, not by accident, but by the skill. I don't say every quack is actually doing wrong things, but many times it is just a temporary effect which makes the patient better. Some people have a lot of knowledge and they work it. But what is the difference between these people and we people? We follow the signs. We have a method by which we evaluate, treat, and re-evaluate, like your thermometer. If somebody has fever, we'll find the fever, give a medicine, and then recheck with the thermometer after some time whether the fever became better or not. So every manipulation can give you some soothing effect, but it may not actually work. Why every manipulation gives you soothing effect, though maybe temporarily? If you could see, these are the bubbles dissolved in our synovial fluid. And when we give a traction to a synovial joint by taking it to that position of manipulation, now the joint opens up. And when the joint opens up, there's a negative pressure created inside the joint, and the gas bubbles, which primarily include carbon dioxide and nitrous oxide, come out of these joints. And this nitrous oxide is a potent vasodilator. It gives a very good feeling of relaxation. So every time you manipulate, it may give you good temporary or permanent effect, depending upon if you've directed in the right direction, it will also do the right things. But this can be deceptive, like this. The pop may come from an area which actually didn't require a manipulation, the hypermobile joint rather than a hypomobile joint. So here is where your skill counts. You have to evaluate and find that particular joint, whether that required manipulation and what direction, and then you treat in the right direction. It will make it better. I have a little example for you. For example, our innominate bone, our ilium, can rotate in many directions. So as a good manual therapist, I have to first find out in which direction the fault has come and then correct it. I cannot simply make the patient lie and do a simple side-on thrust. It may, but it's just a temporary cure. But if I want to make a permanent cure, I have to find that misalignment and correct it. Let's take an example of outflare. I have a little demonstration for you. Outflare is when one of your ilium bones from ASIS goes outward. That means from PSIS is coming in, but from ASIS is going outward. It is very different from your ilium rotating posteriorly or anteriorly, as in the slide here. Or it is very different from the entire ilium going up or down, as in upslip or downslip, as in this slide here. So outflare is when the ilium rotates on this axis, on the horizontal axis, and it goes outward at ASIS. This is what happens in an outflare. The distance from the umbilicus on that side will become more as compared to the opposite side. Patient will have pain and tenderness on PSIS, mind it. He will have the same pain and tenderness on PSIS even in the rotational fault of ilium. But additional thing which has here is tenderness of pubes, which again can come there with some posterior rotation, not with anterior rotation of the ilium. Will have an aggravating activity, but more importantly, such patient will have an externally rotated foot and his leg length will be longer. When the ilium rotates this way, it pivots the acetabulum and the leg becomes longer. But I will use by various manual therapy protocols, like I can do motion palpations, I can do the measuring of the umbilicus to the ASIS, I can do a thermoscan, I can do X-ray findings, leg lengths, and various kinds of things where I want to be sure that the fault is what I am perceiving. For those who are very new to this kind of manual X-ray evaluation, I have drawn one slide here. This is for the same thing which you are doing. That is in pelvic outflare. Now I've taken an AP standing view, not a lying view. And on this AP view, I'm going to mark certain things. First is the first sacral tubercle and the symphysis of the pubis bone. Then I'm marking the top of the head of the both side femur. And then I draw a vertical line, not from the pubic symphysis, but from the sacral tubercle, straight line downwards, and intersect with the line on the femur head. This line should be perpendicular to the line on the femur head. By femoral head line should be perpendicular to this line. And let me see where this line goes. You could see this line, the pubic symphysis is shifted a little to the left on my screen. I don't know on your screen, but marked red here, right here, marked right here. That's red. Marked right here. You could see this shifted to the right. The pubic symphysis is a little here, and this is a little to this side. Not only this, I mark the most medial part of the ilium bone on both the sides, and most lateral part of the ilium bone on both the sides. And then I connect with certain lines. Now, if you see, when a pelvic the ilium goes outward, on PSIS, it will come inwards. That means this PSIS is more close to the sacrum. And this ASIS will be far away. So this line will be bigger and this line will be smaller, as you can see. So this is how, with an X-ray, I can find out an outflare. Right. So then I'm using this leg length. As I said, the side where the fault is, the leg will be longer. That can occur with other faults, but I'm going to verify this with certain maneuver, which I'm going to show you in this video. If you see in this position, the patient's left leg is longer, his right leg is shorter. Now, I'm going to check that. I'm going to verify this. And when I do inflection, they stay the same. In rotational faults of the ilium, they will change. But in this fault, it's same here. And now you see, PSIS has moved inwards in outflare. ASI has gone outward, but PSIS has moved inward. So with my hand, I push this PSIS outward. So I temporarily correct this fault. And now you'll see the leg length on both the sides have become equal. You can, sorry, we lost it in between. Yeah, now you could see on both the sides, the leg length has become equal. Yeah, you could see the mark almost coming, now equal. This was longer and this was shorter. Now, but this is only temporary because I pushed it, temporarily it became better. So I'm using a manipulation. I'm pulling the PSIS which has gone inward, because in outflow PSIS goes in, PSIS goes out. So I'm manipulating using this. This is on a live patient. We did it in a clinic a few days back, and we manipulated and fixed this back. And if you see, now his leg length has become again equal on both the sides. Right. So this is how we found the fault and corrected it. Not only this, we also in manual therapy would like to find the soft tissue which brought that fault. Sometimes it may be a trauma which got the outflare, but most of the times in today's world, it would be because of a myofascial tightness. So the iliolumbar muscle can get this kind of an outflare. If it is tight in the low fibers, if I don't release it, it will bring this fault again and again. That's what I want to say in my next slide. If you want these corrections to be permanent, you don't want the patient to come back again. And especially if the problem was born because of a myofascial postural fault, then you need to work on the soft tissue. Now, this is a jeans branded by Levi's, and they say it's a lifetime free, wash-free jeans. Lifetime, you do not need to wash it. But of course, you don't need to wash when you use like this. But if you use this way, I'm sure you may require to wash it a little bit, but not this way. So if you keep on sitting in awkward positions and you don't work on your myofascial tissues, they'll stay tighter and they'll keep on giving you trouble. So this is a myofascial tissue on both the sides of a bone. It's becoming tight on one side, it's becoming more one side, and it will pull the bone into fault and something breaks here. This gives you pain. You use a class 4 laser or something as good as that, and this becomes better, but only temporarily, because this tissue, which is out here, is going to pull it into the same problem. So we need to break this tissue, which is growing here. That will be the most permanent thing. So this is where we need to work. One, we have to do certain exercises, which are very essential for this problem not to come back. And second, we need to release all those tissues. Like for this example, an out flare, this is the side which is mentioned here. The ilium is internal on this side because it's an out flare. PSIS is internal on this side. So without letting my ASIS go up, I'm doing this exercise and taking both my disconnected legs. They're not connected here. I'm not carrying them in harmony. So I take these legs, and when I do this, my ilium on this side will be pushed outwards, or ASIS will push inwards. This is how I will do a remedial exercise. It's not that I'll do any SI exercise and that will make this problem stay better. And also I need to work on these tight tissues, which we talked about a slide before. Now, these facial tissues need to be identified, and the depth has to be according to the facial tissue. We know there are two types of myofascial layers. One is superficial fascia, and second is the deep fascia with muscles. But these deep fascia can be divided into two layers: aponeurotic fascia and epimesial fascia. My aponeurotic fascia glides and slides over my epimesial fascia, which is right on the top of the muscle to produce the movement. Like my shirt is sliding to let my arm go up. Similarly, my top layer of my aponeurotic fascia has to slide over the epimesial fascia, like this. But with poor posture, lack of exercise, there may be adhesions growing in these tissues over time, and this movement will stop. So if I need to release this bonds to make the fascia glide and slide again. Another very important thing we have been discussing, it's not necessarily where I get this tightness or spasms, I will treat it. Let's take this example. This patient has levator scapulae spasm. And my instinct would have said, oh, needle or release this levator scapulae. But if you see, this gentleman has a forward head posture. He's got a forward head posture on the this area. So what happens when he has a forward head posture? His SCM and anterior sclerae are pulling the head forward. It's like a pull coming from this side, and this poor levator scapulae on the other side with my wash hand is trying to prevent this hand going down or my head going forward. So if SCM is tight, my head has to go forward, but my levator scapulae is stopping it from going. It is applying more force than it is capable of, and then it is going into spasm. So if I release, what will happen? It will only worsen my forward head posture. So once you release the muscle, you have to find which muscle is tight, and you need to specifically first work on those muscles which are the fault creating muscles rather than the muscles which are the victims. Also, it's not a group of muscles in advanced manual therapy we work. We work especially on every little component of the muscle. This is single muscle, erector spinae, which has three components. I call it I love standing, because if I have to stand, I require all these three muscles: iliocostalis, longissimus, and spinalis. All three have different functions. Spinalis is more concerned when I bend forward and backward straight. But if I bend forward and to side, then my longismus is more importantly recruited. And similarly, if I bend forward and rotate, it is my iliocostalis muscle. So if I have a problem coming up from that side and I keep on releasing the spinalis, it won't work. I have to find first by posturology and then by myokinetic techniques, which of this particular muscle is involved. You could see this is spinalis, which is more responsible for your more lordosis or kyphotic curves. This is your longest muscle, which is more responsible for your scoliotic, functional scoliotic curves, not the congenital scoliosis. And this is your iliocostalis, which is more responsible for a rotational thing, which you get one side of the back coming more posterior than the other side. So I need to find which side is at fault and I need to correct it. Here you can see there's a tightness of spinalis because there's a lot of depth in these vertebrae, there's a lot of lordosis. Here on this side, you could see a curve. That means the longismus on this side is tight. In this, you could see it is the iliocostalis on one side, which is more tighter than the other because there's a more posterior curve bulging on one side of the spine. So we find and then we can give. This is a treatment for the longismus muscle. You cannot see there's a mild C curve in the patient when she stands up. And we find that mild C curve. We have evaluated first. And now I'm going and releasing her longismus muscle because it is more recruited in side bending and forward bending. I'm making the patient do both of them together, both side bending and forward bending. So when she goes, I'm exactly on the longismus muscle, which is about approximately 1.5, 2 fingers away from the spine. I can find a rope-like structure. Longismus is the muscle which you feel in erector spinalis. Spinalis is too thin to be felt, and iliocostalis is more flattened. So you can find that rope-like structure, and this is how we are releasing that muscle when the patient is doing the same activity which brings that functional fault. Now, the advantage of releasing this kind of thing is the patient is proprioceptively getting trained to elongate that muscle in the functional use. Normally, if you do only an MFR, it makes the patient become better in lying position. But if once it does a function, it will not be properly recruited. So when we are working on this, we not only should work on the muscle which is involved, we could work on the entire chain. My hand now won't go up because you can't see. I'll try to see, but I'm trying to pull my shirt down from below. Now hand doesn't go up. So this muscle, which is required on pulling it up, my deltoid here, may not work because the fascia down below is not letting it to do. So muscles work in chains. And similarly, if you have an erector spinae problem, I may release his hamstring or plantar fascia and the patient will become better. Might have seen many ladies who come with this kind of problem. Gardan may be dard, kamar may be dard, घुटने में भी दर्द, the palm में भी दर्द. This is because the entire chain is becoming dysfunctional. When you get these kind of things, why? Because the muscles are dysfunctional. So that's what we need to work. We need not to work on a simple system, but it's a little bit more complicated. But remember, if we do the right kind of things, our practice is going to grow like anything. People will come us finding from far off places because they will have you only giving you the solution. They might have gone to 20 people, the answer was not there, but you were the one who could only provide them that solution. So I believe if you learn these techniques, we couldn't do practical here because it's a open webinar. In a closed webinar, or maybe when Corona gets better, I like to show a lot of things practically as well to you. But sure, I'm today that your vision should have changed a little bit. We need to revolutionize. And with this wonderful platform provided by IAP India, where even I'm learning so many things, I randomly go and see certain things. I'm sure my little things might be of some help to you. Thank you very much. Thank you, organizers, for letting me share my whatever little thoughts I had in my mind. Thank you, Smita. Thank you, Dr. Ruchi. Thank you, Dr. Sumanta. Thank you.
Thank you, sir. Thank you so much for enlightening and sharing your knowledge. So we are blessed that you are with us and you are our guide. Well,
Thank
so now we are able to understand manual physical therapy is a specialized form of physical therapy delivered with the hands-on opposed to a device or machine. It has an important place in physiotherapy and when used appropriately by practitioners is a very effective set of tools literally at our fingertips. Anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. So continue learning. I feel blessed to invite Dr. Narendra Sinha sir, President of IIT Bihar chapter, for vote of thanks. He is a legend and he is a self-made man. Sir, are you there, sir? So over to you.
So you need to unmute yourself. Dr. Narendra, kindly unmute yourself.
Okay.
Yes, sir, we can hear you.
Okay.
Thank you.
Thank you. Thank you, Dr. Smita Singh. Good afternoon to all. Here we are at the end of this webinar. I may like to express my sincere thanks to Dr. Manish Arora, Professor and Dean at SBSPGI Dehradun. Dr. Manish is well known to all of us as an academician. This webinar conference is very informative for all the physiotherapists, and I hope everybody will utilize the knowledge gained through this. I would like to thank Dr. Ruchi, National Head and IAP Treasurer, who provided her valuable time in making this webinar successful. I thanks to Dr. Binay Pandey, Vice President IAP Bihar Branch, Dr. Uma Shankar Sinha, Secretary IAP Bihar Branch, Dr. Reena Srivastav, East Zonal Coordinator, Dr. Purnima, Dr. Arpana, and Dr. Roli Prakash for their active participation. My special thanks to Dr. Smita Singh as a coordinator and for being the stimulus for success of this webinar. My deep sense of appreciation goes to her. I would like to thank IAP and all the participants and my best wishes to all of you. Be safe and healthy. Thanks.
Thank you, sir. It was good to hear you after such a long while, Sinha sir.
Thank you.
And
Thank you very much.
you have always been supporting us. I required many times, many documents. You have always guided us, provided us. Thank you, sir, for being there.
Anytime I will support to you and the profession. I stand the support to the profession every time. Thank you very much,
Thank you, sir.
Dr. Manish Arora,
Thank you, sir. Thank
for
you.
nice presentation. Thank you very much.
Thank you, sir. Thanks a lot for being an awesome guide. Well, now I take privilege to thank you all for being a part of our journey. Named and unnamed friends who joined together to make the webinar happen. Special thanks to my team for unconditional support who worked backstage. So be supportive, be careful, be alert, be kind, and be ready to fight coronavirus, right? COVID-19. We'll be meeting again soon with a new beginning. Thanks a lot.
Thank you.
Dear sir, just to have your a few more time, like one of the participants have asked the question, is manual therapy indicated in pregnant women? I think this is Mr. Joe, who has asked on YouTube platform.
Right. Well, with all the safeties and precautions taken, manual therapy is well trained to do that. So we do definitely do manual therapy. We use certain risk-free measures, and we are doing with our patients. I get many patients who are on the family way, and they have this musculoskeletal problems more also because of the pregnancy, because of the weight shift. So we do not use a hardcore manipulation, but we use other softer techniques, and we make them better.
Thank you very much, sir.
Thank you.
Smita, is there any participants from IAP Bihar who would like to ask any questions from sir? Else, we can close the session.
Well, till now, we haven't got any questions here from the audience side. So we can proceed further.
So thank you so very much. It's always a delight to hear you, and and listening after so many years has been a great delight, and it's very smooth, and you have taken, I think, you have shared great secrets with all the physiotherapists that how they can really enhance their skills, and we look forward to learn and help our fellow physiotherapy student and physiotherapy fraternity. And we're really thankful to IAP WC Bihar to have you here as the key speaker. And I'm thankful to IAP Bihar branch for having this wonderful initiative. I would request if IAP Bihar can encourage the students and the physiotherapists in our fraternity to subscribe IAP India channel on YouTube, which can actually show our solidarity, and IAP India as an IAP Help page on Facebook. So I would request all the stakeholders and all the respective teachers and the seniors to kindly promote this as to showcase our solidarity. And we promise that we will continue to bring great topics like this and great key and resource persons like Dr. Manish Arora. And we are grateful to Dr. Sanjeev Jha and Dr. Ruchi Vashne for allowing us to, have this wonderful platform to showcase the skills of our physiotherapists. So thank you once again, Bihar, and thank you, Dr. Manish Arora. It was a pleasure hearing you again. Thank you so much.
Thank you. It was an honor. Thank you. I'm really honored. Thank you. Thank you, Smita. Thank you,
Thanks a
Sinasa.
lot.
Thank you, Vinay. Thank you.